So let's commence with the next speaker, please. I call upon our next speaker, Dr. Priyamvada Yadav from India, to deliver her speech. Thank you.
Hello, good afternoon, everyone. Am I audible?
Yes, please.
Yeah, okay, that's good. Yeah, so greetings from India. First of all, I'd like to thank all the hosts for giving me this wonderful opportunity to present on an international platform. And it will be really wonderful to interact with all of you. So just a brief introduction. I'm Dr. Priyamvada Yadav from India. I have done my MBBS and MS ophthalmology from India only. And after that, I did a fellowship in comprehensive ophthalmology. Currently, I'm working at Regional Institute of Ophthalmology, Postgraduate Institute of Medical Sciences, Haryana, India. So I would like to share my screen. Is my screen visible?
Yes, it's visible. Yes.
Yeah.
Thank
okay.
you.
Yeah. So I would like to acknowledge my co-authors, Dr. Urmil Chawla, who is professor at PGIMS Rohtak, India, Dr. Virendra Singh, who is head and senior professor, Department of Oral and Maxillofacial Surgery, Postgraduate Institute of Dental Sciences, and Dr. Meena from Department of Pathology, PGIMS, Haryana, India. So I hope my slides are visible and I'm audible. Yeah, okay. Today I'd like to discuss the case of mucormycosis in an immunocompetent child, and that too with an atypical presentation. Any suggestions or questions at the end of the presentation are highly welcome. So a brief introduction. Mucormycosis is an acute or subacute, rapidly progressive infection by angioinvasive fungus of the order Mucorales. It can prove to be a deadly disease in patients who have poorly controlled diabetes mellitus or the patients who are immunocompromised. It has a very rare incidence in patients who are immunocompetent. So mucorales are the second most common organisms after Aspergillus in hematological malignancies, hematopoietic stem cell transplantation, and solid organ transplantation. Besides, its occurrence has also been noted after trauma or iatrogenic injury in patients with uncontrolled diabetes and after natural disasters. The common species that infect humans are Rhizopus, Lectemia, Apophycomyces, Mucor, and Rhizomucor. The human infections are less commonly caused by Cunninghamella and Saxenia. The fungus thrives on decaying plant debris and soil. Now, the type of mucormycosis that has been seen in humans, the most common type is rhino-orbitocerebral that usually starts with the paranasal sinuses, then spreads to the orbit, and from there it can spread to the brain. Second common type is the cutaneous that usually occurs following inoculation of the fungus inside the skin following any form of trauma. The fungus is ubiquitous in nature. Pulmonary type can occur following inhalation of spores. The gastrointestinal type can occur following ingestion. Disseminated variety is little less common, and the term is given to the infection when it affects two or more than two organs that are non-contiguous. Isolated involvement has also been noted, like isolated involvement of lymph nodes, liver, kidney, urinary bladder, uterus. These can also occur, but these are rarer. Now, the most common type is the rhino-orbitocerebral mucormycosis. It's commonly due to Rhizopus oryzae, and almost always it is seen in immunocompromised patients. That is, the patients who have uncontrolled diabetes mellitus, the patients who have been on chronic steroid therapy, and patients with hematological malignancies. Besides, it can occur in hematopoietic stem cell or solid organ transplant, patients having retroviral disease, malnourishment, and particularly in patients who have an iron overload state. Now, because the fungus is ubiquitous in nature, so that means we can find it anywhere. So how do we normally avoid this? So the course in immunocompetent host usually follows like the spores are inhaled and through the cilia in the nose, they are directed to the pharynx. This is then eliminated by the gastrointestinal tract. So the phagocytosis in an immunocompetent host effectively contains the infection. In patients who are immunocompromised, the condition becomes little different. These patients have impaired phagocytosis. In these patients, the spores of the fungus get a chance to germinate. And then these hyphae, these spores which germinate into hyphae, they go for angioinvasion. Now they happen to destroy the internal elastic lamina of the arteries. And once this angioinvasion has occurred by these hyphae, they incite an inflammatory reaction. And all this combined lead to thrombosis of the vessels. Now, this thrombosis of the vessels leads to tissue necrosis because of infarction. And that leads to the characteristic eschar formation that is seen with this infection. That is the hallmark of this condition. Now, in case of rhino-orbitocerebral mucormycosis, the path usually followed by the fungus is the initial site is nasal turbinates, where it goes through the environment by inhalation, and the spores get deposited there. Now, this is followed by sinusitis, and this sinusitis can further progress into pansinusitis. Now, once all the sinuses have been invaded and there occurs angioinvasion, there is infarction, there can be bone erosion. So then from the sinuses, there can be involvement of the palate, there can be involvement of the orbit, and there can be involvement of the brain. Now, brain can be involved either from the orbit. Once the sinuses, the infection has gone from the sinuses to the orbit, this can go from the orbit to the brain, or sometimes the infection can directly go through the sinuses themselves to the brain. There also, the pathogenesis remains same. Because of angioinvasion, there is tissue ischemia and necrosis. So the spread, as we have discussed, is usually there is angioinvasion and bone erosion that is followed by orbital involvement, and subsequently there is involvement of brain. Sometimes directly the infection spreads from the ethmoidal sinuses to the frontal lobes, or the infection can also spread from the sphenoid sinuses and lead to cavernous sinus thrombosis. Now, the histopathological examination. The smears used are wet KOH preparation. The scraped smears are of hematoxylin and eosin and papanicula. Air-dried smears of periodic acid schiff and May Grunwald chimsa. The surgical sections are processed in paraffin and examined under these stains. Now, once, as we know, mucormycosis, debridement of the infected tissue is one of the bases in the management, is one of the management protocols. So the debrided tissue, again, we look for the histopathology, and what we look for there are elongated, broad, ribbon-like hyphae that are irregularly branching at right or obtuse angles, and they have no or scanty septations. We can also see thrombosed blood vessels with significant necrotic areas and giant cell inflammatory reaction. There can be widespread infiltration with lymphocytes, eosinophils, and occasional plasma cells. Now, these can be seen by some special stains also, like calcofluor white or Grocott-Gomery methenamine silver staining, and they demonstrate twisted septate hyphae. Coming to the case report. So the case report is of a 2-year-old female child who presented to our ophthalmology OPD, and the parents gave the history. They complained of a swelling in the kid's right upper and lower lid since 3 weeks. The swelling, as per history, was gradually increasing in size, and it increased in size after sleep. There was history of some nasal discharge few days before the swelling started. There was no history of any significant trauma. There was history of consultation for these symptoms with some local practitioner, but no relief in symptoms was noted. There was history of no other systemic illness. On clinical examination, general examination, the child was little irritable. The body weight, this was a 2-year-old female child, and she had a body weight of 8 kilograms, and the child was anemic. Local examination regarding the vision, the child followed objects with both the eyes. On palpation, there was a woody hard swelling with erythema in the right lower and upper lid. Both globes appeared normal. There was no proptosis, conjunctival congestion, or chemosis. The pupils of both the eyes were round, 3 millimeter in size, reacting to light with no relative afferent pupillary defect. The ocular movements were also grossly full, and the fundus showed a good glow. Now, this was the condition of the child at presentation. And as per the history, this was the swelling which was gradually increasing in size, and it was noted to increase following sleep. So this was, the child was having swelling more in the lower lid compared to right. And as we can see here, it was more tense, it was woody hard, and it was giving a tense feel, more so nasally towards the medial canthus. Now, we admitted the child and investigated. So the HP of the child was 9.1 gram% at presentation. Excuse me. Now this HP dropped down further to 7.8 gram% during follow-ups. So blood transfusions were also given, and following transfusion, it stepped up to 12 gram%. The total leukocyte count at the time of admission was 18,000. The peripheral blood film showed few microcytic hypochromic cells. The rest blood investigations were found to be within normal limits. Initial blood cultures were normal, and ultrasound abdomen was also found to be within normal limits. Now, looking at the condition and suspecting it to be a cellulitis, we started the patient on intravenous broad spectrum antibiotics that covered gram-positive, gram-negative, and anaerobic organisms. But no response was noted even after 3 days of initiation of the treatment. We got an ENT consult, and in the ENT review, there were no significant findings noted. The endoscopic examination was also found to be within normal limits, and only decongestants were given from the ENT side. Pediatric opinion was sought in view of low weight and anemia. From there also, conservative treatment was started. Now, when the child didn't respond to it and nasally, the swelling tended to become more tense. So we did an incision and drainage from the dependent portion, but that revealed no pus and only blood was noted. Now, this put us into a diagnostic dilemma. The child was not responding to any antibiotics, broad spectrum antibiotics, and on incision and drainage also, there was no pus, only blood was there. So, what was the thing? We got the child imaged. So, CT scan of the orbits and paranasal sinuses was performed, and that showed mild maxillary sinus roof thickening on the same side, that is the right side, along with an ill-defined soft tissue attenuating lesion in the region of medial canthus of right orbit, adjacent to the nasolacrimal duct, indenting the right globe from inferonasal side, with a likely infective or inflammatory etiology. So as we can see here in the right globe, so adjacent to the medial canthus, here was some mass that is indenting the globe from this side. So this was indentation from the inferonasal side, adjacent to the nasolacrimal duct. An ultrasound of the local area, this area was performed, and this was suggestive of diffuse subcutaneous thickening with intense vascularity in the preseptal region of the side, extending to the infraorbital compartment. Again, with a query of it being an infective or inflammatory lesion. So none of the investigations were actually coming to help. Following this, we performed a contrast enhanced MRI brain with orbits. Now, this was suggestive of a large lobulated enhancing mass, in a heterogeneously enhancing mass in the subcutaneous tissue of the right maxillary region, which was infiltrating into the lower lid and further into the inferomedial extraconal compartment of the right eye, with a suspicion of neoplastic process with the query of rhabdomyosarcoma. So now to the diagnosis basket, one more differential was added, and that was of rhabdomyosarcoma in a child in which the swelling was not resolving despite broad spectrum antibiotics. No pus was there, and we got a heterogeneously enhancing mass which was compressing the globe from one side, and now we had a suspicion of it being either an infective lesion or inflammatory, and then contrast enhanced MRI came up with another DD that was rhabdomyosarcoma. So we can have a look at the MRI pictures of the child. If we come to these pictures, so this is the right side, and here we can see this mass was progressively increasing. So at the time of presentation, when we saw the child, it was there in the right upper and lower lid only, more so in the lower lid. But during the course, we saw it to be increasing, and it had increased to involve the maxillary region. It was involving mainly the subcutaneous region in the maxillary region. So we can see here this involvement has increased up to this area on the right side. And if we come here on these sections, we can see here it has come up to the jawline here. Now, because now there was we had 3 DDs, we went for an incisional biopsy on day 7. And this was sent for histopathological examination and fungal culture. Now, the biopsy report was suggestive of fibrocollagenous tissue with infiltration by inflammatory cells. There was intense inflammatory response, inflammatory exudates, and fungal colonies with closest resemblance to mucormycosis. So we did get a frank diagnosis of mucormycosis. This was just a closest resemblance. Now, because there has to be a high index of suspicion for fungal infections, so we started the child, excuse me, on intravenous liposomal amphotericin B. The condition remained static initially, and a few days later, it again started to increase. So it further increased down the maxillary region and involved the upper lip on the same side. Now, once this had increased to this much level, now debulking had to be performed. The DDs in mind till this time were: one was rhabdomyosarcoma, and second was fungal infection, mucormycosis. So debulking had to be done in any case. Suspecting it to be a rhabdomyosarcoma, in that case also, if we perform debulking, that was going to reduce the dose of chemotherapy or radiotherapy that had to be given subsequently. And if it was fungal mucormycosis, as the biopsy was revealing the closest resemblance, in that case, this is one of the modalities, rather one of the key points that has to be done. Debulking surgical debridement is very important. So in collaboration with the maxillofacial surgeon from the institute, we did debulking in our ophthalmology OT. Meanwhile, antibiotics were also, systemic antibiotics were again added for super-added Pseudomonas infection. Despite debulking, the mass again continued to increase, and it progressed with deviation of the nasal bridge to the left side, the other side. Now, after debulking, when this tissue was sent for examination, the findings of biopsy revealed a soft to firm gray-white mass with fibrocollagenous and muscular tissue that was infiltrated by inflammatory cells and colonies of fungus. Special stains like GMS, they revealed broad aseptate hyphae that was suggestive of mucormycosis with severe necrosis. So we can have a look at the gross appearance of the tissue. So this was from the maxillary region, and we removed multiple pieces with this appearance from this area, from the intraorbital compartment as well. So this was soft, creamish, white to creamish, firm to rubbery consistency mass. Now the GMS stain, you can see here, it revealed broad aseptate hyphae, ribbon-like broad aseptate hyphae, branching at 45 to 90 degree, or sometimes obtuse, at obtuse angles also. So here again, we can see there is a focus of necrosis with giant cell reaction. Now, once we had debrided, we had put a drain there. So at the time of suture removal from the site, we noted some pus at the site of drain. Now that pus was sent for culture sensitivity. The condition again remains static for many days after this debulking, but again there was increase, and this time it extended to the upper lip and forehead glabular region. Now, because it had been quite some time that we had started in liposomal amphotericin B, and the child was not responding much, so syrup posaconazole was also added in appropriate dose, and followed by substitution with injection voriconazole. This was done in view of certain reports. There have been few reports of mucormycosis in immunocompetent patients, and these reports say that immunocompromised patients respond better to amphotericin B, whereas patients who are immunocompetent and have mucormycosis, they respond better to injection voriconazole. In view of that, this was substituted by injection voriconazole. Now, here we can see how it serially progressed. So initially the swelling was there only in the upper and lower lid, more in the lower lid. Then it further progressed to the maxillary region, then to the upper lip area, and then from here to the opposite side also, causing the deviation. And then the nose was also, nasal bridge was also deviated to other side. We can pay particular attention to the color of the skin. initially the color of the skin was it was erythematous only, but with time we can see here that the color was it had little bit of erythema here, but here nowhere was there sign of any blackening. But with time this child developed. So this was almost 1.5 months following the child presented for the first time that she developed this kind of skin discoloration. When we are seeing a patient of mucormycosis, at the first instance, we are usually expecting because of angio invasion. We happen to find an eschar that is usually seen. But here, this discoloration was noted after almost 1.5 months following the initial presentation. Now, a dental examination was done. So they noted an erythematous area in the buccal mucosa of the right side. So this swelling kept on progressing. This time it involved the post-septal compartment of the orbit also. So some proptosis developed and that led to corneal exposure. So again, a debridement was planned and it was done. Now, this biopsy again revealed fibrocellular connective tissue with multiple granulomas, necrosis, and non-septate fungal hyphae. Now, this was the picture of the child following the second debridement. So, if we notice here, now the picture here is the child seems to be drowsy. This was because an imaging was planned, an MRI was planned, and for that the child was sedated. So that is why this look. So this is following the third debridement. So the child had developed some proptosis, and because of that there was corneal exposure. So we had put a moist chamber over there along with conservative management, and plus then followed by a debulking was there, and then it went to, so this is following debridement. When it has gone to its normal position, there is no proptosis seen at this point. Now, when the child was admitted during the hospital stay, the child developed many systemic co-infections, like urine culture revealed Acinetobacter species. Then a repeat urine culture was done that revealed Citrobacter. The blood cultures that was initially sterile when the child was admitted, that showed wet time Staph aureus. A repeat culture showed Acinetobacter. Now, for all these, the child had been on appropriate antibiotics time and again. So now, in this particular case, as we noted, rhino-orbitocerebral mucormycosis, we know it is usually seen in immunocompromised patients, in patients who have iron overload, and the usual path taken is there is first involvement of the paranasal sinuses. From there, there is involvement of the orbits, and through the orbits, there is involvement of the brain. The brain can directly be involved following infection of the paranasal sinuses also. But here, as we saw, though the child was malnourished, was little underweight, but apart from, like, she was advised high protein diet, and no specific thing was done by the pediatrics department. This much is okay, this will do. And even the HP that was 9 gram percent at presentation, and it further dropped to 7 gram percent during the course, and she had to receive certain blood transfusions also. So the child was anemic. So this was not a state of iron overload. The child was not immunocompromised. There was no history of trauma. There was no involvement of the paranasal sinuses from the very beginning. So this was something that started from the orbit, and like, so it gave us, like, one of the DDs was bacterial cellulitis. So it started from the orbit, but then slowly and progressively it involved the maxillary region, the subcutaneous region. Till date, the child has still been on follow-up with us, and there has been no involvement of the brain and the paranasal sinuses. So it has been primarily the orbital involvement along with the subcutaneous region of the maxillary area. So This is the usual path is paranasal sinuses to orbits to brain, and it is seen in immunocompromised patients, patients with iron overload. Isolated orbital and cutaneous involvement can occur, as we have seen in this child, and an immunocompetent host may also be affected. This child has no particular problem with the immune system. There was no immunocompromised state. So, as for any other case, our management goals here, they remain high index of suspicion. Like here, we had imaging studies revealing something else, our clinical diagnosis was something else. So, this is something that may give, as we saw in this child, the particular the specific discoloration that develops because of the angioinvasion that developed so late. So from initial presentation till almost 1.5 months, we had a skin, the color skin that was only there was some erythema. That was a sign of inflammation. We didn't see any blackening. There was no involvement of the sinuses, and even the skin didn't show any blackening till 1.5 months following the affection. So a high index of suspicion is must. So even immunocompetent patients may be affected, and patients who are anemic also. So iron overload is not a necessary factor. So a high index of suspicion has always to be maintained to diagnose it early. Appropriate tests have to be done, and very important is timely antifungal agents along with surgical debridement of the tissue for tissue and life salvage. It has to be done. So suspicion and suspicion, that is the key point. Even if the patient is immunocompetent and we don't see any risk factor, even then it should be suspected. Now, during the COVID era also, one special thing I'd like to mention. Now, during these COVID pandemic also, we have come across many patients of mucormycosis. Uh, can't say what has been the exact cause behind that, but most of these patients had history of COVID occurring, and they were given methylprednisolone for that. But such a short thing like short course of methylprednisolone and that leading to development of mucormycosis in patients who were otherwise okay, otherwise who had no immunocompromised state, that still needs to be studied what were the exact causes. But yes, there has been a certain rise in cases of mucormycosis during this COVID pandemic. And this child also presented to us during the pandemic also, but there was no frank history of COVID in the child or in the child's any of the child's family members. So the key points are high index of suspicion and timely antifungals with surgical debridement for tissue and life salvage. So suspicion, suspicion, and suspicion in any patient, that is a must. So these are a few of the references. And thank you so much for your time. And any questions or suggestions or discussion, highly welcome.
Thank you very much, Dr. Yadav, for this informative session. And I would just like to ask if any of the participants has got any questions to ask from Dr. Yadav, please. Anyone? So if you would like to ask any question, you can drop it in chat box, please. And well, I have one question, please. What would be the most appropriate test you mentioned? So can you name a few which to determine mucormycosis, please?
Yeah. So as we have seen, biopsy is one thing that would tell us, because culture also we can't rely, because sometimes there can be mucor can be a contaminant also. So just getting mucor on culture can't be, we can't appropriately label it as having mucormycosis. So I think biopsy and this histopathological examination, that is the most important test.
More specific as compared to that. Right. Thank you very much for your time. Okay. Take care. Thank you.
Thank you.
So now we are going to invite